The ethical issue that we'll be discussing arises from the concern that some individuals with autism or other developmental disabilities engage in severe aggressive behavior and SIB. This severe aggressive behavior and SIB can pose significant threats to themselves, peers, staff, teachers, and parents who work with them. The ethical code promotes the use of least restrictive procedures. The code specifically states that behavior analysts review and appraise the restrictiveness of procedures and always recommend the least restrictive procedures likely to be effective. However, those providing services to the individuals with severe problem behaviors may consider the use of restraints and/or seclusion after stating these to be necessary to prevent severe self-harm or harm to other people. Today, we're going to be discussing whether or when and where the use of restraints and seclusion are ethical. What role should a behavior analyst play in interventions involving restraints and seclusion? What role should the behavior analyst play in interventions involving restraints and seclusion? And what the literature indicates. We'll first be discussing least restrictive environment and inclusion with students with disabilities in the public school system, and what first have to be addressed before implementing the seclusion or a more restrictive environment. This ethical issue discusses the pros and the cons of including individuals with autism and other developmental disabilities in regular general education classrooms, including those who engage in SIB or severe aggressive behavior.
Okay, before we address the inclusion of individuals with autism and disabilities in a general public education classroom, let's take a quick look at IDEA. IDEA gears that law provides for free appropriate education in the least restrictive environment for children with disabilities. However, nor law nor regulations delineate how school districts are to specifically determine the least restrictive environment. Now, IDEA does not force the placement of students with disabilities in regular education classrooms, but rather fully supports the continuum of placements. This means that students with disabilities should be educated in regular education classroom settings, but only when such settings are appropriate to students' educational and social needs. Advocates of full inclusion believe that the current system of removing students from full participation in regular education fails to serve their individualized needs, results in uneven approach to delivering educational services, is unnecessarily stigmatized, and deprives students with disabilities of the rich and diverse environment of regular education that is necessary for their academic and social development. On the other hand, others argue in favor of retaining the continuum of educational placement while advocating for educating children in the environment most appropriate for that individual student's needs. Also, believing that regular education teachers are not appropriately trained to work with students with disabilities. And much of the clamor for full inclusion is not based on evidence, but on feelings that it's just the right thing to do. So now the question about what is the least restrictive environment arises. And this question is, should regular education classrooms be considered the least restrictive environment and therefore the recommended placement for all pupils? And also, what conditions it is appropriate to use specialized settings away from regular classrooms arise?
So there are various court case decisions involving school systems versus the children with disabilities, and their advocates have helped to delineate a way to decide what environment is least restrictive. Throughout these cases, the school system and those who counter the inclusion of the individual with disabilities, what they argue is that the student needs constant supervision, which could be a hassle. Also, they say that there is little educational benefit for these students. They also tend to believe that the students are disruptive in class. The teachers will have to modify their curriculum completely, and the students would make some progress in a regular classroom, but they might make greater progress in special classes where he or she would receive rehearsal and practice on basic skills in an individualized setting. They also say, they could be physically aggressive towards their peers or their teachers even, and they don't demonstrate problem behavior in special education classrooms as much as they do in a regular classroom. And some of them they believe are just too severely disabled. But even though they make all of these arguments fail to establish that the educational benefits of the special education classroom were better or even equal to the benefits of the regular classroom. School districts make good faith efforts to mainstream students in the regular classroom placement with appropriate aids and services. They have to make data-based decisions. They can't merely just make a token gesture, and they also have to be authentic attempts at inclusion.
Right, and these court cases and research illustrate the important steps that a school must take before deciding which environment is best for the individual, and if the school has taken the appropriate steps to finding the least restrictive environment. The successful least restrictive environment process involves the use of supplementary aids that includes modifying the curriculum for the student with special needs, adding resources to the classrooms, adding teacher aides and paraprofessionals, including parallel instruction and behavioral plans specific for the child. Interventions including curriculum plans and behavioral management plans that are targeted specifically for that individual and that include a plan for self-injurious behavior and aggressive behavior towards others. Appropriate adequate special education support and consultation to the regular classroom teacher. So all of these things must be tried and have to fail before a child is moved from an inclusive setting to a more restrictive setting. There is a strong research base to support the education of children with disabilities alongside their non-disabled peers. Although separate classes with lower students to teacher ratio, controlled environments, and specially trained staff would seem to offer benefits to a child with a disability, research fails to demonstrate the effectiveness of such programs. There is also additional evidence that other than a smaller class size, there is little that is special about the special education system, and that the negative effects of separating children with disabilities from their peers far outweigh any benefit to smaller classes. Students with disabilities in inclusive classrooms show academic gains in a number of areas, including improving performances on standardized tests, masteries of IEP goals, grades, on-task behavior, and their motivation to learn. Moreover, placement in inclusive classrooms does not interfere with the academic performance of students without disabilities with respect to the amount of allocated time and engagement, instructional time, the rate of interpretation to planned activities, and students' achievement on test scores and report card grades. In addition, students with intellectual disabilities educated in general education settings have been found to score higher on literacy measures than students educated in segregated settings. Now, the factors that affect the placement in regular education with supplementary aids and services versus special education that need to be weighed include the academic benefits, the non-academic benefits, social effects, communication, language modeling, role modeling, self-esteem, and behavior models. The important question that needs to be asked is the student being educated in a setting other than the regular classroom where he or she is interacting with typically developing peers? And research has shown that children with disabilities thrive more in a setting where they have higher functioning peers than if they were in a setting with lower functioning peers. And the school must provide the child with as much exposure to non-disabled children as possible. For example, in lunch, recess, physical activities, music, and art. Now, on the other hand, if the student with disabilities is extremely disruptive or exhibits behavior that interfere with the regular education and the behavior management plans do not ameliorate the problem, a more restrictive setting should be considered. Schools must also consider cost of supplementary aids and services. If the cost is so great that it would have an impact on the education of other children in the district, then education in that setting is not appropriate. Because of these cases, the law requires that to the maximum extent possible, appropriate children appropriate. Children with disabilities be educated with children who are not disabled, and separated or removed only when the nature or severity of the disability is such that education in a regular classroom with the use of supplementary aids and services does not work.
So now that we've answered questions about the use of seclusion and more restrictive settings in the public school system, we're going to talk about the role the behavior analyst would serve. So the behavior analyst would enter the public school classroom, observe the child and the behaviors he or she engages in, and will preferably run a functional behavioral assessment to find out the function of the child's behavior problems and where the deficits lie. The behavioral analyst will then have to create a behavior modification plan encompassing only the most recent evidence-based procedures. Depending on the disruption, harm, function, and effects of the child's behavior problem, procedures might include response blocking or removing the child from the classroom or activity that he or she is participating in. A behavioral analyst might also be responsible for implementing or training others on the implementation of procedures, as well as collecting data to evaluate the effectiveness of treatment. So what are some examples of instances when the child cannot be removed from the classroom activity? For example, an escape-maintain behavior that functioned to end an activity would be placed on extinction by not allowing the child to leave the activity. Another example, during circle time, if a child continuously leaves the area, he must be redirected and blocked from leaving. So what about if he aggressed and engages in behaviors that disrupt the teacher from completing the activity? In this case, it is possible to include practicing circle times in smaller groups and in other settings besides that classroom before having him join the group. Implement a break procedure in which the child gets to escape group after a certain amount of time, and that time is systematically increased and definitely reinforcing the target behavior. These and other evidence-based least restrictive procedures must be used before the implementation for restrictive procedures are applied. And always the benefits should outweigh the risks.
Okay, we're going to take a quick look back at IDEA. So under IDEA, services and supports may be provided in preschool classroom, childcare, the home, and or other locations, and families with less resources can find funds. And also there's high quality programs in the classroom and home programs, and they can be funded by Head Start, IDEA, Title I, state pre-K, local funds, foundations, private players, or a combination. So before a school decides that a child cannot function in an inclusive setting, all of these funds and all of these resources have to be used and depleted before they can move the child to a more restrictive setting.
That's great. Yeah, so that is how seclusion and restrictive procedures are viewed in the public school system. So now let's take a look at how these things are looked at in other settings.
One moment. The use of restraints within other settings is pretty well known within inpatient treatment settings and dental offices. So I'm going to show you. All right. Focusing on the inpatient treatment settings, one location had to use multiple different restraints for clients. According to Surrender, 40% of the patients were restrained at one point or another in this location. The most common type of restraint used included timeout and therapeutic holding. However, mechanical types of restraints used included, were typically used for patients who were older or who had a lower functioning level. The other types of restraints that could potentially be used within the setting, other than timeouts or therapeutic holding, included seclusion and the mechanical restraints. Seclusion restraints typically include removing the patient or client from the current setting into a solitary environment to help control behaviors. Timeout restraints remove the clients from the setting as well in an attempt to control their behaviors. Mechanical restraints, however, end up using a 4 or 5-point restraint, as shown in the picture, which ends up securing the individual's legs and arms to a bed. Using more of a physical touch, therapeutic holding is a type of technique where staff members hold the client who is having a severe behavior. In general, using restraints can pose conflicts, but Sarander and others stated that restraints could be benefiting clients in terms of helping them control their behaviors. Additionally, they mentioned how if staff do not restrain and interfere, this might be seen as an ethical issue in terms of abuse and neglect. Overall, it's a pretty difficult situation, but some studies have shown how children and adolescents who are being restrained feel safe and cared for, which is quite opposite of what we would assume they would feel. In general, this particular setting showed a relatively positive view of restraints. Looking at the dental care system, restraints are typically used either by a parent or healthcare professional. Children with ASD, unfortunately, have a pretty high rate of poor healthcare, which could be due to a number of different reasons. For one, it might be due to the fact that there aren't many dentists who are willing to work with individuals with ASD, or they might not be properly trained to deal with the communication issues, problem behaviors, or sensory processing issues. The type of restraint most widely used includes having the child being restrained by the parent or the dental professional through holding down the patient's arms and legs. The parents of these children show a positive view of restraints because they feel that their child might not have access to dental care without having these restraints. It's difficult for children with ASD to attend in the first place, so having them attend with putting items in their mouth to clean their mouths are pretty difficult. Another parent stated that restraints helped provide a safe and effective environment instead of having to deal with the problem behaviors during a dental exam. Interestingly, parents had mixed views about who should be restraining their child. Some stated that they believed their use of restraints was more helpful, and on the other hand, some parents reported that they would rather sign a consent form to have the dental professionals do the restraining for the procedures instead of themselves. However, the use of restraints within a pediatric setting has shown negative views as opposed to the previous settings. The types of restraints typically used within this environment include seclusion and physical restraints. Within this setting, seclusion is when the child is placed in a separate room by themselves by the professionals. The professionals also tend to use physical restraints when necessary. One of the studies regarding a pediatric psychiatric setting concluded that the Substance Abuse and Mental Health Administration, along with a number of other health departments, began to limit the use of restraints. Their reasoning for limiting restraint use were that the use of restraints could potentially damage the parent-therapist relationships as well as the client-therapist relationships. Also, for psychiatric patients, there have been some past experiences that tend to evoke behaviors because of previous seclusions and restraints. Lastly, there might be health consequences to restraints, such as a lack of oxygen, possible blood clotting, and other potential issues that could occur.
As you can see, there's many different areas that seclusion and restraints can be used in, and there's also varying views on how people view restraints and seclusion depending on where they are and who is actually viewing them at the time. So could there be possible ethical issues that are involved with restraints and seclusion?
So the use of seclusion and restraint brings up lots of questions regarding procedures of practice, training, and continued education. Earlier today, we discussed seclusion and restraint in the school system, other settings, and best practice for a client with disabilities. At this time, I will present information that looks at the ethical issues related to seclusion and restraint. Schuerman et al. Discusses the Code of Professional Practice and Ethics. Overall, these procedures should be looked at and regulated at a federal or state level, and the questions raised here should be part of a policy discussion relating to these professional practices. These often violate ethical and legal regulations and will be further discussed. I identified 6 areas of importance that are related to the professional and ethical issues related to seclusion and restraint. Recently, cases contributed to the growing concern of the client's safety, efficacy of practice, and if the schools and the public system are suitable enough to use these procedures on children. Schuerman et al. Found that after further examination of each code and professional practice,
Many of these issues raised were not previously identified in research. The first problem identified is there is always a potential for death or injury to the child. Child Welfare in 2004 reported that 8 to 10 children per year die from restraint. Scout 2009 said that there are hundreds of cases of abuse and death. These cases range from asphyxiation, where restraining a person's face could give them a lack of oxygen, and aspiration, physical trauma, and cardiac issues. According to Bailey and Birch 2016, Code 2.0, a behavior analyst's responsibility to clients, we must practice and deliver Code 2.05, which is the rights and prerogatives of our clients. Overall, our clients' rights are of utmost importance, and we must support their legal right to a safe, effective education. The ethical questions considered are: is it even ethical to use procedures that could potentially kill or injure a child? There are several reported cases where parents are not identified, and there is no parental consent to use these controversial measures. And furthermore, no research exists on the full extent of the possible risks of these interventions. So, is that ethical? The second ethical issue with seclusion and restraint is a result from a failed use of the least restrictive intervention. This may be due to the improper use of techniques or failure to use them effectively in early intervention at the start of the behavior problem. There are a hierarchical behavior management plan in place, and these may not be monitored, used properly, or even used at all. Given these guidelines, one would think to use the safe and effective evidence-based practices and require all professionals who work with children who have challenging behaviors to be competent in using these type of techniques prior to using any seclusion and or restraint. Right. Ethically, the question becomes, are the staff equipped and skilled to use these preventative techniques? The BACB has already clearly addressed seclusion and restraint. Code 2.09, ineffective treatment or intervention efficacy, describing first determining if it would be effective for this intervention for short and long-term well-being of the client. According to Bailey and Birch in Code 4.08, considerations regarding punishment procedures, it is important to try reinforcement first and receive proper consent before implementing these procedures. Code 7.02, ethical violations by others and risk of harm. There may be a risk of harm or legal violation, and it may be considered unethical. According to this issue, these could be potential violations to the code of conduct. The third ethical issue is the inappropriate restrictions on liberty or removal from access to an education. Are these practices posing violation to basic human, civil, and constitutional rights? Seclusion or restraint itself may result in the student being removed from the education room for significant amounts of time. Currently, no data exists on the recommended duration of restraint and seclusion, and the media is flooded with cases of abuse and neglect after inappropriately long amounts of time away from the classroom. This becomes a huge concern ethically because those students with special needs already have lower performing scores as compared to peers, and Sutherland and Webby 2001 found that these academic shortfalls are contributed to some of the most challenging behaviors occurring. Through these current ethical issues, issue number 4 is the repeated use of potentially dangerous and ineffective interventions. Several cases have reported using restraint 10, 12, maybe 15 times in a public school setting, and advocates suggest that the continued use of restraint as an ongoing behavior reduction intervention is an indicator that the intervention is not working at all. If that's just to confine a child for an extended amount of time, what is the threshold? And furthermore, at what point does this intervention need to change because the behavior is not improving? These questions shouldn't be handled within the school district or part of an IEP meeting, but decided at a federal or state level. The fifth current issue is a disproportionate amount of use with restraint and seclusion in minority groups. Seclusion and restraint was measured in a sample of almost 39,000 individuals, and 12% of those had disabilities. Out of the disabled group, 69% of those were restrained. The U.S. Department of Education also claimed that 42% of those were either Hispanic and 21% African American. This does concern professionals due to these procedures being disproportionately used on minority students with disabilities. The issue raised here looks at the treatment plan in place based on the group the student belongs to. Is there a disproportionate amount of seclusion and restraint in certain groups? Yeah, there is. These findings promote questions about the efficacy of education practices in specific groups. Finally, the sixth ethical concern for seclusion and restraint is the lack of training, supervision, and monitoring occurring with the staff who execute these procedures. Gao 2009 reported that most incidences involving seclusion and restraint were due to the lack of insufficient training procedures. These incidences could have been prevented, but due to the lack of oversight and proper procedure training, this is troubling. Looking at the bigger picture, 50% of students with behavior disabilities are in general education classrooms. Some teachers are not trained in the procedures or strategies to really de-escalate the outburst. Overall, ineffective programming on the teacher's part may produce more challenging behaviors altogether. Colvian et al., according to Colvian et al., this in turn makes it harder for the student to thrive in an inclusion classroom. Most educators receive training on crisis management, but fail to prevent these type of incidences. Most professional organizations use seclusion and restraint as an emergency protocol only, not in response to a behavior automatically like the teachers are trained to do. Because the educators rely on these tools, behaviors typically escalate to the point of emergency due to the response. According to Code 4.09, clients are entitled to the least restricted procedures first before seclusion or restraint is considered. Without proper training, how would this be possible? Many ethical questions can be raised on these points alone. Is it ethical to place children in the care of a teacher where they have not been trained in de-escalation practices? Overall, the most important piece is the child, peer, and staff safety. So it wouldn't make more sense to look at a better solution than continue this risky process. The CCBD, which is the Council for Children with Behavior Disorders, provides various policy recommendations regarding the use of physical restraint and seclusion. These behavior interventions should promote the well-being and the rights of the child to be treated with great dignity. This should be done in the least restrictive environment with positive and appropriate interventions to support their mental health and safety. Included in safety is the importance of training staff to employ these techniques. The school should provide enough staff to effectively provide these positive supports. These trainings not only help with de-escalating the situation, but they also diffuse crisis and conflict situations. They require training on the use of positive behavior support to properly follow where more intrusive measures may be used. Ultimately, each child is entitled to an appropriate behavior assessment to determine which behavioral plan will work out best for the child and the inclusion of strategies to really de-escalate their own behaviors. According to CCBD, based on the principles, restraint should only be used when a physical safety of a student or others appear. They should apply to all students, not only those with special needs. The use of restraint should be under the supervision of a physician and included in the child's IEP. The restraint should be conducted by a person who's certified, has annual updates, has skills for positive prevention methods, and is informed about the effects of medication, be CPR certified, and be able to use the portable auto electric defibrillator in case of an emergency. They also give a clear idea of when restraints should be used to control the behavior and how to tell if a situation is really an emergency or not. The student should be posing clear, present, imminent danger. All other less restrictive measures should be deemed inappropriate and ineffective. The restraint itself must be only long enough to resolve the actual risk of danger. The CCBD also states that restraint should not be used as teaching moments or as punishment. It should be used as continuous behavior and it should not be used as continuous behavior management programs. Prone and supine restraint should not be used at all. Ultimately, they would like to see all workers involved documented along with parents and program supervisors to be notified immediately. The CCBD also lists some exceptions based on the principles. They include police officers and vehicle restraints as an exception to these rules. Globally speaking, these principles are based on the research and failure of this type of physical restraint. The CCBD recognizes that the repeated use of physical restraint on students should be reviewed as a failure of the individual's education program, as well as the school's failed response. Each student should have a safety planning and individualized safety and emergency plan given the likelihood of a crisis like this.
That's great. So we have viewed a lot of different things today. We talked about the use of restraints and seclusion in not only the school system, but also in many different areas. And we've also just looked at the ethical issues that could possibly be there. Natasha brought up 6 different facts that are absolutely incredible. So before we conclude, a few questions that we're going to have Sherry Evans to answer. First question is, a lack of training is a potential issue for those who perform restraints. Are there any strategies or methods that can help improve training for administering restraints and or decrease the need for restraints?
All right, thanks, Zach. As we just heard from Natasha a minute ago, the CCBD has stressed the importance of proper training for those who perform restraints in schools, and the prevention methods being the most critical here. Their research prevents effective guidelines that could be used in any setting. So their recommendations implicitly state that physical restraint should only be conducted by staff who has been trained. And Ethical Code 4.08 states that analysts recommend reinforcement rather than punishment whenever that's possible. Training must include conflict de-escalation and positive support training to diffuse situations before there is a need to use restraints. Staff must attend updated trainings each year and also be CPR certified. With proper training, the need to use restraints should be decreased as staff learn effective ways to work with clients to de-escalate. This is imperative to following the BACB ethical code regarding least restrictive procedures, boundaries of competence, and maintaining competence through professional development.
Fantastic. All right, I have a second question for you. The use of restraints or seclusion vary from setting to setting. For example, in Indiana, mechanical restraints are not recommended to be used for people with adult services. Is it ethical to use this as a way to address behavior if it's not something that can be used across various settings? Like what happens if a child has a mechanical restraint in one setting but then moves on to a new setting where that type of
Zach, I would once again point to the things that Natasha brought up, and I would stress the importance of the CCBD guidelines to understanding this question. So mechanical restraint should only be used to support individuals orthopedically and should never be used to manage their behavior. So even when used as a mechanical aid, it's imperative that mechanical restraints are used only with the supervision of a physician. Extinguishing the use of mechanical restraints prevents the ethical concerns that would accompany the switch in settings and restraint techniques. And then a final question, does any of us have any personal experience related to this topic that we would like to share? One time, when shadowing a boy who exhibited autism characteristics but had not yet been diagnosed, he was in a typically developing kindergarten classroom with a teacher at a public school. I was able to aid him so that he could follow simple instructions. For example, he was able to follow the teacher when asked to take out his pencil and math book and turn to a specific page. He was able to master computerized testing as well as the skills needed to perform spelling tests such as listening, numbering, and spelling. Even though things were going well for him, during an IEP meeting, his mother was not informed that she could have me or my supervisor attend, and she went alone. So the school attacked his mother and said that he was not making progress and needed to be moved to a special classroom with a more restrictive environment. Thank goodness I had taken baseline intervention data and kept copies of the test and worksheets that he had completed. Because of this, the school was forced to keep my client in the least restrictive environment by adding supplemental aid.
Overall, there are both positive and negative views of restraints, and there are scenarios where restraints might be absolutely necessary. But in general, as behavior analysts, we want to use the least restrictive environment. Thank you.